All right, so the topic really essentially is these axial aching disorders, which are not like rheumatoid arthritis, so it's more proximal rather than like distal, which is very classic, you know, for like rheumatoid arthritis. So we're going to look at polymyalgia rheumatica, polymyositis, and fibromyalgia. So looking at the polymyalgia column, it's a synovitis is what we're going to see. It's going to be the joint and the bursa that are affected. There's no weakness, really, so it's more so achiness, and usually, you know, there's this, oh, the person's weak. That's a common misconception. Usually it's that they're very painful, and therefore it kind of confounds the fact that they actually don't have any weakness. It's painful, they have a high ESR, and they are responsive to low-dose steroids, 15 to 20 milligrams daily. With polymyositis, they tend not to have pain, so this is also a misnomer. They have more so proximal weakness. It's very symmetric. So no pain or very minimal, so maybe some tenderness, and they have positive myositis-associated antibodies. They're steroid responsive and also immunosuppressive responsive. With fibromyalgia now, that's also axial, but it tends to be more so of nervous system dysregulation. So they get sleep disturbance. It has to do with the central neurotransmitters, really the components in the brain. No true weakness. Yes, they may have some tender points, but no labs are diagnostic, and serotonergic drugs are what we're going to use. So with fibromyalgia, it tends to be chronic 3-month non-inflammatory, non-immune central afferent processing disorder leading to this diffuse pain syndrome. There's a 2010 diagnostic criteria, which, you know, it's not so much in favor, but this is essentially what we're using right now. So it's chronic widespread, at least 3 months, above and below the waist on both sides of the body. It's called, what we use to measure is really essentially the widespread pain index. It's pain induced on palpation, at least 11 of 18 tender points. I'm going to show you the diagram. No other causes for the symptoms should be diagnosed. On physical exam, lab tests, and radiographs. So just as I mentioned before, the labs are going to be completely normal, no reason to check any rheumatoid factor or any A&E, and those should be negative. So this is a tender point count, largely discredited now, but still is somewhat useful clinically. So just on palpation, it should be like 4 kilograms per meter square in terms of the pressure that's applied. I mean, we don't really measure that clinically, but it's just a rough guide. Should be able to blanch the your fingernail. So when you apply the pressure, that's, you know you're applying enough pressure. So there's no arthritis. Affects about 3 to 4% of the population. Middle age, so young to middle aged. Mostly female, predominantly. Small proportion of rheumatology practices, and you know, there are definitely other factors. Just historically, it's had different names, but they're not going to really ask you anything about that. For some people, you know, there is a familial disposition. Also associated with people have other psychiatric diseases or disorders, bipolar disease, OCD. These people tend to be a little bit more predisposed as well. You do have some genes that are involved as well. So definitely, if you have, you know, a patient who before seeing you said, oh, you know, I had a sleep study, I'm not sleeping well, they have alpha intrusions. Alpha intrusions are actually something that are very characteristic, and they will have this, you know, in our patients who have fibromyalgia. Sleep apnea, they are at increased risk of cardiovascular risk, Another thing that may disturb sleep is early rheumatoid arthritis. Of course, when we're sleeping, the hands are in these different positions, but usually wrist complaints are very common and wakes up the patient in the middle of the night. And thyroid studies are also something that we want to make sure that we check before. And that's just, looking at a paper, with the non-REM sleep, not getting enough REM sleep is actually going to predispose you to fibromyalgia. So family history of sensitivity syndromes, blood pressure, neck size. So definitely if you're doing like a myelopathy, patients who have, more soft tissue around the neck, more predisposed to sleep apnea. So oral exam, difficult myelopathy is also, going to be suggestive. Vitamin D level is helpful because you also want to rule out osteomalacia. Do not measure the rheumatoid factor or A&E unless there's objective joint swelling. And if there's objective joint swelling, then there's perhaps some other disorder rather than fibromyalgia or in addition to fibromyalgia. Radiographs needed only if they're painful sites. If you definitely see synovitis on clinical exam, and this is out of proportion to other areas. If generalized, there's no need to, go ahead and get radiographs. You can do functional MRIs. These are for, cases that we are not certain about, and if they have significant complaints, but this would not be something typically that we would do, but it does show that there is increased activity in areas involved with pain perception and emotional modulation versus like normal controls. So therapy components, definitely patient education, analgesia, correction of sleep disturbance is very high on the list, so definitely sleep hygiene is important. Both sleep latency and then sleep duration is very important. Aerobic exercises, non-weight bearing to some extent, and land exercises rather than aquatic tend to be very helpful. Physical therapy, treatment of any associated disorders, cognitive behavioral therapy, supportive counseling, and pharmacologic therapy. For pharmacologic therapy, we tend to use combination neurotransmitter inhibitors. So duloxetine, you want to use patients who also have depressed mood, fatigue, and osteoarthritis of the back and knees. So this would be one of the drugs that you could use if the patient has multiple symptoms. Milnacipran, patients with cognitive dysfunction, this is very helpful for them. So cognitive dysfunction and fatigue, you can definitely use this. Anticonvulsants like pregabalin, good with patients who have sleep disturbance as well. You can also use venlafaxine, tricyclic, cyclobenzaprine, gabapentin. Others like tramadol, less likely to be used, so it's usually used as like a last resort. And then like transcranial direct current stimulation, that's also, like a last resort therapy. So really it's just rule out secondary causes, rule out arthritis, and then cognitive behavioral therapy, exercises, and then last pharmacologic therapy for patients with fibromyalgia. So the next one with axial involvement is polymyositis and other, inflammatory myositis types. So this is a conventional classification. You have adult polymyositis, dermatomyositis, juvenile myositis, more so dermatomyositis than polymyositis. And I'll just, briefly just mention that with pediatrics, they get the dermatomyositis, but they do not have the cancer risk that's associated with like adult dermatomyositis, but they have more so calcinosis. You have malignancy-associated myositis in overlap with other autoimmune diseases, and inclusion body myositis, which we'll also mention, go into a little detail as well, how to differentiate that from your classic overlap of dermatomyositis, polymyositis. So the diagnostic criteria, so it's going to be proximal motor weakness. So this is, even though it's myositis, they have some tenderness, but it's not painful, it's more so weakness. Elevated serum muscle enzymes, your CK, your aldolase, certainly. Abnormal neurodiagnostic studies, so you want to get your EMG as part of your workup. And they're going to have a myopathic pattern rather than a neuropathic pattern. If they do have a neuropathic pattern as well, you want to think of inclusion body myositis. Muscle biopsy is key, as well as the characteristic rash for those who do have dermatomyositis. So this is essentially the part what we are going to use for our diagnostic criteria. This is the classic heliotrope rash, and you can see it in people of different complexions. You know, it's difficult to diagnose sometimes. Sometimes it's very faint. Sometimes it can be a little more prominent. And then you have your Gottran's papules going to occur right over the joints. If you have it in the region in between the joints, more so in the soft tissue, you want to think more so of lupus. So that's something that you need to differentiate. You can also get it on the knees as well. This is the anti-CA-DM 140. This one, if you see it, you're not likely to be tested on it. This is a cancer-associated dermatomyositis. They get a lot more ulcerations, and they have rapidly progressive ILD. So the MRI isn't part of the diagnostic criteria, but is certainly helpful. So we look for a T2 signal on or MRI, which shows edema and inflammation. If you do have a T1 signal, that sometimes represents fat that has already replaced the muscle. So it's not active disease. The patient's not likely to respond to therapy. So that's also, something. But ideally, you want to look for T2 lighting up on the MRI, T2 signal. So here, and you certainly see it in particular muscle groups. So extramuscular and extradermatologic manifestations, you can have ILD, pulmonary hypertension, and aspiration pneumonia, because they can also get diaphragmatic weakness. They can get esophageal dysmotility and rectal incontinence. All of these are all muscle related. EKG abnormalities, they can get conduction blocks and myocarditis. Now, if they have predominantly like myocarditis, you wouldn't expect to get an elevated CK or ESR. You would get more so elevated troponin, so that's also always something to consider. Vascular, you get the vasculitis, you can get skin ulcerations as we had seen before, and you can get Raynaud's. So classic polymyositis, dermatomyositis, you're going to get elevated CK, aldolase, and liver enzymes. And that comes from liver abnormalities, liver inflammation, Elevated ESR. So the CRP may be normal. If you do get a high CRP, then you want to think that this could also be muscle necrosis going on, and the patient's perhaps going to be resistant to therapy. More than 50% tend to have a positive ANE, so it's not unreasonable to check that. Anti-RNP, PMCL, SCL, and anti-CU, these are all like overlap syndromes, so some patients actually do have overlap, and you can see features, as we mentioned before, that can overlap with like scleroderma. So elevated troponin, if myocardial involvement, so the CK does not correlate if you have myocardial involvement. So this is just a diagram showing like the multiple antibodies that you can get. The anti-Jo1, you're likely to see, definitely with antisynthetase syndrome. It is protective, so it's negative correlation with malignancy for patients who have like dermatomyositis, as well as the MI2, which is for classic dermatomyositis. SRP, anti-SRP is very resistant myositis. And the MDA5 is malignancy associated. The others you're not likely to get tested on. The HMG coreductase you want to check the antibodies here if patients you've had on statins do get elevated CK and you're thinking of a statin myopathy, which tends to be resistant. You want to perhaps check these antibodies. So that is something to consider. Yeah, and that's what I just mentioned before. So malignancy and amyopathic dermatomyositis. With children, they're not going to have the malignancy risk that you would see in adults. They do get more calcinosis, so they will have dermatomyositis, clinically present very similarly without the muscle disease, but they present with a rash. They do not have increased cancer risk. For adults with amyopathic dermatomyositis, there is increased cancer risk. Not just at the time, so you want to make sure that they have age-appropriate screening, but even up to 3 to 5 years after diagnosis, you still want to make sure that you do screen them because they are still at risk of getting malignancy. The anti-Jo1 and the anti-MI2 have a negative association with malignancy, but you should still make sure that they have age-appropriate screening. So, sorry for the typo. The treatment approach, really, corticosteroids are the mainstay of therapy. You want to do 1 to 1.5 milligrams per kilograms per day. You start, essentially what we say is start for weakness and you stop for enzymes. So when the muscle enzymes normalize, at that point you can really essentially want to start tapering your steroids. Adding immunosuppressives for steroid-sparing effect, methotrexate, azathioprine, Cellcept, cyclophosphamide. Methotrexate tends to be the most common one, up to like 25 milligrams weekly you can add as a steroid-sparing agent. Some people start it immediately. When you start the steroids, it's not necessary to do so. The patient's responding when you start the corticosteroids, it's not unreasonable to, when you start tapering, to go ahead and start the methotrexate. Cellcept is also very good, especially if the patient has ILD. Plaquenil is good, if the patient has significant skin findings. You want to avoid sun exposure, and overall, this is very good for skin. Remember, eye screening definitely at baseline and annually after that for retinal toxicity with the Plaquenil. Tacrolimus and cyclosporin, these are calcineurin inhibitors that we do use if the patient has very resistant myositis. IVIG is useful for patients with dysphagia. And then rituximab you can also use kind of more like an apex drug type. And then Acthar gel, which is essentially repository corticotropin, very infrequently used, is very expensive, and essentially last resort. So for patients with polymyositis, dermatomyositis, most patients, you're definitely, if not all, you're going to start your corticosteroids and then perhaps use a steroid sparing, usually like methotrexate or like Cellcept as well. For inclusion body myositis, they have both proximal as well as distal muscle disease, and it tends to be asymmetric, unlike our classic polymyositis, dermatomyositis. Tends to be males, usually over the age of 50, and what they tend to present with is falls. So a patient will come and say, I've been tripping lately. Not only check their vitamin D level, but also definitely think that this could be inclusion body myositis. They tend to have distally, finger flexors are weak, so that's one area that you want to check. And usually you want to have the thumb with the index, and then you try to test the strength there, and also with the little finger as well. They should be able to resist. If not, then you also want to think that they have finger flexor weakness, so that's important to consider. And then so it's proximal as well as distal, but it's also asymmetric. No myositis-specific antibodies, unlike what we saw with the polymyositis, dermatomyositis. So there's essentially not anything you can really check for. Not going to be anti-Jo1 or CADM or any of these others. They may also have mild peripheral neuropathy, and they get loss of the deep tendon reflexes. So when you do the EMG, unlike the classic polymyositis, dermatomyositis, where it's just a myopathic picture where it's polyphasic, they get fibrillations, insertional, hyperactivity. This one, you will get that, but in addition to neuropathic changes as well. So if you see both neuropathy as well as myopathy, definitely think inclusion body myositis. On muscle biopsy, you're going to see red rimmed vacuoles. And so if you see this, certainly in a question, this is perhaps what they're thinking of, and you stain with the Gomori stain. This as well, if you get a case that says they're not responding to steroids or they have very minimal response, it could be, yes, that they have a resistant myositis, but these myositis do tend to show some response. So this shows very minimal response, and at that point, if you were thinking another type of myositis, definitely think inclusion body myositis. Unfortunately, there's not many treatments, it doesn't really respond to anything really, and the prognosis is pretty poor. At a recent conference, we had a couple of cases with patients with inclusion body myositis. We still, tried corticosteroids, immunosuppressants. Some patients do have some minimal response, and you can prolong some function, but on a whole, they're minimal or not responsive to steroids or immunosuppressive therapy. So moving on to polymyalgia rheumatica and temporal arteritis. So giant cell arteritis, again, most of these conditions you see tend to be older patients. As they get older, there's an increased risk, especially patients over 80 years old, more at risk of patients who are younger. 20% will present with a superficial headache, scalp tenderness, jaw or tongue claudication. The jaw claudication tends to be the most specific sign. You can have overlap of GCA and PMR. 10 to 20% of patients who have PMR also may develop GCA, and 40 to 50% of patients with GCA have PMR symptoms. The most dreaded complication is blindness. That can be seen up to 15% of patients. And you should also consider extracranial areas to aorta, up to 50% to 80% on imaging when they're not clinically detectable. Internal carotid and vertebral arteries may also be involved. So unlike your other types of vasculitis, temporal artery disease with GCA tends to be more so from the adventitious, so outwards, inwards is what really happens in the classic pattern of inflammation. So the ESR is almost always higher than 50 millimeters per hour. You do get an elevated CRP. With regards to doing the biopsy, of course you have skip lesions. So, clinically what we do in the rheumatology clinic is you can feel for the pulse, but also to feel if the vessel itself is firm and rigid. Can you feel it? Can you compress it? And you want to just feel right along the zygoma. It's called the Fisher-Miller sign. If you feel any beating, are you feeling a good pulse? Can you, stop the pulse and then, see it return after removing your hand? If it's difficult or the patient doesn't present, with minimal headache, sometimes you can actually use ultrasound guided imaging, and you see a halo sign around the artery. Properly performed biopsy can actually give you a diagnosis in about 85% of the cases and, define the need for therapy. Two types can either be granulomatous or pan-arteritis when, the whole thing is affected, and there must be an inflammatory infiltrate in order to diagnose GCA. So even if the patient's on steroids, you have up to 14 days essentially. What happens is that it removes the inflammatory infiltrate, but it doesn't reverse the damage that's already been done to the artery. A PET scan can also demonstrate any extracranial artery involvement or any aortic involvement, because a lot of these patients also have aortic involvement. So here appears to be involvement of the subclavian artery. So this is one of the studies that can be used if you have, if you question whether or not there's extracranial involvement. So this is essentially dilatation, and this is from a real classic patient, that we had that had aortic involvement. So management, essentially high-dose steroids, much higher than the dose that we would use for our PMR. So 60 milligrams daily. You can break this up over, twice daily. Can also use pulse methylpred initially, and that's 1 gram over 3 days. Tend to be dramatically effective. Steroid-sparing agents can also be used. Methotrexate. All patients should be on low-dose aspirin as well to reduce the risk of the cardiovascular events and also blindness. So in addition to the steroids, also definitely start them on low-dose aspirin. A good measure when you know how to taper steroids is when there's, normalization of the inflammatory markers, ESR and the CRP. Certainly consider surgery, especially if there's aortic, artery involvement, and significantly, at least if they've reached 5 centimeters, certainly surgical intervention is warranted. 5 clinical conundrums you may or may not experience. What is it? Visual loss is never really defined. Any change should be considered something that is significant. So not necessarily someone saying, oh, I had a veil over my eyes or anything clinically suggestive of amaurosis fugax. You don't need to go to that extent. If they say, look, my eyes are blurred, that's certainly something, to consider. Delayed large vessel complications, not everybody presents initially, but also definitely consider anybody with chest pain, back pain, pain radiating to the back that they could have an aortic aneurysm. It's difficult to risk stratify patients. Steroid sparing, whether or not start methotrexate. Some people do endorse like IL-6 inhibitor like tocilizumab. So yeah, number 5, really is, we have other targets that we can perhaps use. So with PMR, it tends to be a subacute onset, severe pain and stiffness in the proximal limb. So it's not weakness that they have. This is confounded. So when you ask them to raise their arms, can they, get up? Or it tends to be more so pain that they're experiencing that's making it difficult rather than like intrinsic muscle weakness. Patient, again, middle-aged to elderly, increased risk as they get older. Elevated ESR, more than 40 millimeters per hour, elevated CRP as well. Negative rheumatoid factor and CCP. They may, however, have a non-erosive asymmetric arthritis, so that would not be unusual, and it dramatically responds to 15 to 20 milligrams daily of prednisone, unlike a higher dose that we use in the GCA. Treatment often, needs to be done for at least 2 years. There is increased risk of relapse. So tapering, you have to be very slow, very cautious with tapering because relapses are essentially frequent. I think that's it. Yeah, so essentially, this is just, back to our first slide, our summary slide. PMR, definitely going to see synovitis, joint bursa affected, no weakness, it's painful, have elevated inflammatory markers, low dose prednisone, 15 to 20 milligrams daily. They're very responsive, can use a steroid sparing agent like methotrexate, and you certainly, use tocilizumab perhaps as well. Polymyositis, dermatomyositis, it's a misnomer. There is more so weakness rather than pain. They can be tender. It's symmetric, more so proximal. They have positive antibodies, so ANA is positive 50 to 80% of people. Anti-Jo1, you definitely want to check those. They are responsive to steroids as well as immunosuppressive therapy. Don't forget extra-articular manifestations, ILD certainly, and then the skin manifestations as well. Some of them are quite responsive to Plaquenil. Fibromyalgia, sleep disturbance, essentially negative antibodies, so no elevated ESR CRP, no ANA, no rheumatoid factor. If you do have these, you need to be thinking that there is an associated condition. No weakness. They have the tender points. No labs are going to be diagnostic here. And then, physical therapy, sleep, and then, or pharmacologic therapy. So, yeah. Thank you.
I have a quick question. What type of extra imaging should we do for GCA patients? So are we ordering echoes or CTAs or MRAs? Or what should we be ordering?
Right. So clinically, definitely you want to palpate the artery. You have extracranial involvement apart from the temporal artery, can have subclavian, can have aorta. Initially, ultrasound at the temples. You can look for the halo sign. Also helps to see which areas actively involved. You can do an echo initially, especially if you have a high suspicion that this patient with PMR can have GCA, or a patient with GCA presents with headache elsewhere. What I didn't mention is that it doesn't always have to be the temporal artery. Can be superior occipital as well. They're not going to present with headache. They may present with syncope. You can get echo initially if you think that their large vessels are involved. So echocardiogram. You can get CT angio. You can also get a PET scan. I think I had a diagram with PET scan. That's going to show you the high activity. So really, it's individualized per patient, but none of those is wrong to do if you think that is certainly indicated. Because with GCA, you can have aneurysms, risk of aneurysmal dilatation, and dissection. So ultrasound, CT angio, MRI, and PET scan, or PET CT as well, because we've also been able to do anatomy as well as function with the PET CTs.